as part of the overall delivery for IMTP, very closely with those services to understand whether it is no additional that require recruitment or no additional because we can realign workforce skill mix, etc., within the current service. But as it stands, that was the position when we put forward the IMTP, and that is what has been built into the IMTP. The element of the plan that relates to, and it's called bridging the gap, because in previous plans, what we have set out is literally what do we need to do additionally to deliver the IMTP, and we've not then incorporated how do we reduce our vacancy levels across the organisation. And so that bridging the gap is setting a target for reduction of vacancy levels across services. They are based on establishment, so funded establishment to actuals in post. They are based on those things. In the strategy, though, you'll also see reference to a number of areas. One, very clearly, the service and workforce reviews, which colleagues will know we have undertaken to identify and what do we need to deliver a safe and high quality service. A good example of that was the emergency department reviews that were undertaken that then informed the case for investment, as well as the improvement plan that would then result in a priming of workforce with potentially an element of that workforce reducing as we improve our delivery over a 3 to 4 year period. So that's a really good example of where we are working with services to understand, have we got the right workforce? Have we got the right skills and attributes? And very much focused around the team, around the patient, rather than just the traditional workforce replacement like for like. And as a result of that, working with the schemes and the IMTP, but also those bridging the gap, we will either be working through realignment of resources, both people and finances within the existing budget, or that will lead into development of the next IMTP, so the refresh of the IMTP, which is why we're really clear that this is the 2022-23 recruitment requirement, which also enables my team to be really focused on this is what we need to deliver. But this is the 2022-23 recruitment requirement. There will be likely changes across staff groups in that requirement, but we have to work on the basis that if there are significant areas where the current establishment isn't where it needs to be, that aren't built into the IMTP, unless there is a significant risk or unless implementing a change would result in efficiencies, resulting in savings, they will need to be built into the planning for next year as part of our planning cycle. Does that answer your question, Lucy?
Yes, it does. It does. I suppose the other thing that's brought up with me quite frequently is the difficulty that our service has recruiting to even the funded posts in terms of the establishment control. And therefore they tell me they find it easier to go for an interim because it's a much quicker process. So for us to be able to deliver the strategy and get the right workforce, obviously we need to try and break down those barriers. So is that the plan as well?
Yes. So in the strategy, we've been really clear. We have to make sure our processes are fit for purpose, as well as our attraction and retention. But our processes have to be fit for purpose. Colleagues will know that we commissioned an independent recruitment improvement review kind of late on in 2021-22. That recruitment improvement review is based on improvement methodology, as Jo said earlier on. We reported an update to PPPH committee at the last meeting, so last week. And we are going to continue to report progress against that recruitment process improvement review at each of the PPPH committees. We're also, as the chairman alluded to, we are going to be undertaking a deep dive, and we have had discussions about having a board workshop, which clearly would be me and my team, but would also be key executive leaders as well, in terms of particularly the professional groups. So that is absolutely within the plan. We have set an improvement target for 2022-23 to bring our time to hire down, for example, from the current average of 84 days from vacancy creation to final offer, down to 49 days in 2022-23. We are on track with that. We are not an outlier in All Wales. We are actually, for a number of the metrics, the third highest, i.e. best deliverers in Wales, but we know that we need significant improvement. So the challenge for us over 2022-23 is to reduce that time to hire from vacancy creation through to final offer, including contract, down to the 49-day mark. I believe we could go further than that. So I've also set the team a stretch target, which is 43 days for 2022-23. And of course, we will be reporting progress against that through PPPH.
Thanks very much for that. So my absolute final point, because I know there are others who want to come in and conscious of the time, but can I just put in a plea as well? Primary care resilience, of course, isn't just about GPs or even nurses. We really need to be focused on trying to attract community pharmacists to our area as well. That there's big concern about our community pharmacy workforce. So just to make sure that we still have focus on that. Thank you.
No, absolutely, Lucy, and that's partly why I made sure I was. So I'm joint chair of the Strategic Primary Care Workforce Stream on an All Wales basis, and I've been linking in very closely with both HEIW, but also with Gareth and clearly Gemma and other colleagues around making sure that we're looking at that team around the patient. That goes for all settings. It's really, really important that we focus more, including all of our performance reporting, because of course primary care features when it's employed in our performance reporting, but not necessarily in our independent sector. So it's really absolutely critical, and I believe that that's set out in the strategy moving forward.
Thanks, Lucy. And so, Joe, did you want to come in next? I see your hand's gone up.
Yes, please, Chairman. Just in response to Lucy's point with regard to pharmacy, we know that one of the effective drivers of recruitment and retention is education, training and learning opportunities in North Wales. We've seen that with the development of speech and language therapy degree courses being offered in North Wales for the first time. And we are in active conversations with university partners and with education funders to see the development of a degree pharmacy-based course up in North Wales. Now, that's not a 5-minute fix, Lucy, obviously, but is an example of where we're working at recruitment from both from an operational, tactical and strategic point of view. Thank you very much.
Thanks, Joe. Richard, next, please.
Thanks, Mark. The bulk of what I was going to ask was actually covered by Lucy's question and Sue's pretty comprehensive response. Clearly, it is very important that we reconcile the workforce planning with the IMTP and the budget, because workforce is a very significant, huge percentage of our annual expenditure. So I'm not going to labour on that one much, other than say that perhaps it would be beneficial to have some sort of reconciliation process between the budget and the official establishment, and I think that would be a valuable discipline. What I'd like to ask, though, besides that, is the timing of this strategy and its production and renewal. Sue described in her last response that this is the 2022-23 recruitment requirement. It's a bit unfortunate we're getting this on the 26th of May, because that means we're 2 months through the year. Could you set out what you think would be the timetable over the coming several months for the next annual refresh of this? Because in an ideal world, when we're setting our IMTP next time round, it should be done in conjunction with all of the relevant resources, financial, workforce, and all the other things as well. So that ideally, again, big word ideally, they all come to the board in a completed state somewhere around February, March each year, so that we can start the new year in April with a clean slate of plans and proposals to go forward. So something on the timetable would be useful. And just as an adjunct to that, Sue Hill is intending, I think, to bring a timetabling paper to PFIG somewhere in the next few weeks, setting out the timetable for the budget development over the course of the next several months. Would you, the other Sue, consider such a thing for renewing the workforce strategy?
Okay, so if I could take, so you made a comment about it would be helpful for us to reconcile the ledger with the establishment. So when I first arrived in 2018, we did just that. And that's when we put establishment control in. So establishment control is perceived by many to be a vacancy control process. And for a period of time it was. But establishment control is to do exactly that. It is to reconcile constantly the ledger and ESR. So what is in our funded establishment is reconciled across our electronic staff record and our general ledger. So finance and workforce teams worked really hard in 2018 and have continued to work really hard in maintaining the alignment across. Just in terms of the bringing it here on the 26th of May, so just for clarity, the plan element, the people plan element of the people strategy and plan was Appendix 4 in the IMTP that was approved by the board on the 30th of March. And so it has been, and it is an integral part of the IMTP. It was also part of the IMTP that was submitted to Welsh Government. So just to clarify that, this is exactly the document, albeit I've put an additional explanatory note into the document because of the comments where at the board when this strategy and plan were last presented at the board on the 30th of March, the same day as the IMTP. Clearly, and I think Sue Hill referenced it earlier, we have a very integrated medium-term plan. Our finance, our people, and our priorities are aligned. So the timeline that Sue and Chris are going to be bringing in terms of that timeline for refresh of the IMTP will incorporate refresh of the people and workforce plan as well. So sorry if I've confused things, but this is the document that was I think it was Appendix 4 of the IMTP that was approved by the board on the 30th of March and was submitted to Welsh Government.
Okay, thank you.
Okay, Jill, John, Jackie, then I'm going to draw this to a close. Can I ask colleagues to note that we are now running over 20 minutes late? Can I ask people to be succinct? Can I ask you to concentrate on the new points that you might wish to make or questions? There is no need for repetition on points that have already been covered. Thank you. Jill.
Okay, Mark, I'll be as brief as I can. So it is to support, but also enhance the point that Sue's made about the IMTP, but also the transformation piece that we're doing. And if I use the RTC as an example, the people strategy is allowing us to be flexible on what those new roles might be in the future and how that will influence both our people strategy internally, but our conversations externally with education providers.
Okay, thanks, Jill. John, then Jackie.
Yeah, thanks, Chair. Just one very quick point, really, and that is in relation to lots of the areas that we're talking about, there are problems with recruitment, and currently we're having interviews where there might only be one person applying, but in other areas we might have 30 people applying. So linking back into the training aspect and recognising that the training for a lot of these jobs is not a 12-month period, 3-year period, etc. It's a longer term. So my question is around how are we actually aligning our requirements for key positions with training. And the other fundamental question, which I suppose we all should be asking, is what will be the potential timeline when patients and our citizens actually see levels of improvement that they then have confidence in the health service in North Wales?
Okay, so if I answer the alignment with training, so as it sets out in the strategy, and in, of course, John, you will have seen more of the detail in the draft delivery plan that came to PPPH last week. We are really clear, very clear, that our forward workforce planning is essential. So we have undertaken a considerable amount of work and are actually leading a number of pieces of work on a national level around forward workforce planning, using scenarios as well to link into that. That then informs our commissioning, and you'll see that the commissioning numbers are built into the plan, but also the alignment of our commissioning to our workforce planning as well as our delivery planning are intrinsically linked. So my belief is that the strategy sets out how we will ensure that our future workforce planning incorporates commissioning of education, both academic and vocational. Also, our talent management and our succession planning has to be focused more on growing our own in North Wales as well as in BCU. So I'm mindful of time, so I don't want to labour that point. In terms of that timeline of when will the citizens of North Wales see improvement, that on its own today is particularly given the context that we're in today, is an answer that I don't believe I can answer today, but is something that clearly the executive team and the executive SROs for the senior responsible officers for the work streams will be working through as we finalise the deliverables. The deliverables will be going back with outcomes against them. We'll be going back to PPPH at its next meeting as we agreed last week. And I think at that point we will have a clearer view as to when we want to be able to see tangible improvements across our population. But I do think we need to recognise that this is a 3-year strategy. Improvement at the level that we are requiring as an organisation will take time, but clearly we need to set out what we would envisage seeing within this financial year at the PPPH committee next time. Thank you.
Thanks both, and finally Jackie.
Thanks, Mark. It refers to Sue's comment then around growing your own, in fact, and a concern around the way that we develop our lower banded staff. It would be really helpful to make sure that whatever we produce doesn't restrict the development because it's not in their job description for the job they're doing, but recognises that staff might want to move on in the organisation. So you may run the risk of losing your member of staff, but that is better for the organisation in terms of development for them as well. And the other comment is around HCPC professionals. A lot of those are developing apprenticeship programmes currently, and to make sure that we have a weather eye on that, and improving our policies and procedures in support of our staff, in particularly the study leave policy, and to keep a weather eye on recruitment and retention premia wherever we may need to. Thanks, I'll leave it at that. Thanks, Mark.
Thanks, Jackie. Sue, did you want to respond at all?
Briefly. So as somebody who started as a youth trainee and an office junior, that area for me is well, I'm very passionate about making sure that everybody can reach their potential. The career escalators, and that sounds like a fancy title, but people being able to see wherever they are in the organisation what they could aspire to and how they could get there from a learning and development and opportunities for learning new things, being exposed to new things is really, really critical. This is an area that I don't believe that we have focused enough on as an organisation. And you'll see in the numbers when we're talking about apprentice numbers, we've set ourselves quite a challenging target for this year. I believe we need to be aiming to exceed that in terms of the numbers of apprentices over the year. I think the proposition of rotational roles, or being able to experience different pieces of work, different environments in a planned and purposeful way, is something that we do need to embrace. And actually at an All Wales level, we've been talking about how do we do that so that people can work across organisations if opportunities don't exist within the current organisation for a period of time. So absolutely, couldn't agree with you more, Jackie.
Right, helpful exchange, I should say, between colleagues and Sue. Are you happy on the back of that exchange and the further work being done with PPH to agree the strategy and plan now? So yes from Richard. Are other colleagues happy to?
Yeah.
Yes.
Thank you.
Yeah.
Thanks, Sue, for all the work that's gone into it. We look forward to seeing progress reported through PPH committee in terms of both the strategy and the plan. Thank you. Okay, I'm going to move us on then. So we now move on to the chair's assurance reports that are listed at item 3.E. And the first is from you, John, and Petrie. Is there anything you would particularly want to highlight in terms of the report, John?
Sorry, Mark, couldn't get the microphone turned on. I'll keep it brief. Really, there's three areas to escalate to the board, which are the concerns around stroke performance and the ongoing, notwithstanding that there's activity going on, the performance around planned care and unscheduled care. A number of risks were identified, but also some things to celebrate in terms of the delivery of a very small surplus from a financial point of view as well. Which I think, whilst the audit's got to be done, it's still something to recognise in terms of performance last year. I'll stop it there.
Thanks, John, and we'll come on to the performance issues. Thank you. So I'll move us on then to Charitable Funds Committee. Jackie, anything from you?
No, Mark, it's all in the paper there. The key risk in the decrease in income that we may see, particularly due to the cost of living issues at the moment. But that's it. Thank you.
Jackie, there's reference to more frequent trustees meetings. Is that something that you're going to discuss with Joe and I?
It is indeed, yes, Mark. We don't have enough of them.
Okay, can we pick up outside then, please?
Yes, yeah.
Yes, thanks, Jackie. Okay, so SRG, Claire.
Thanks, Chair. Oh, camera off, camera on. Oh, I'll talk even if my camera's off. Oh, apologies. I think probably the main thing to highlight, obviously we've had the opportunity to review and comment on a number of items which the board has been considering or which are in development, but we started a bigger conversation, I think, about how we can build the influence of the stakeholder reference group, which you referred to, Chair, earlier today. And some of that's about our attendance levels are not always good from some of the stakeholder partners, and we're doing some work to understand why, but also trying to build in much better feedback from the board to the group, and then making sure that the group's voice can be heard effectively at board. And then alongside that, with Helen, we're starting a piece of work around representation at the stakeholder reference group, because we feel there are a number of groups across Wales, North Wales, that probably aren't adequately represented at the group at the moment. So as those plans develop, we'll come and talk with the chair and the board about that. Thank you.
Thanks, Claire. I think we've agreed that if you can't make board meetings, your vice chair will do so. And I'm happy to do the same in terms of HBF as well. So I think we've agreed that, Claire, haven't we?
We have, yeah. Thank you, Chair. Yeah.
Thank you. Okay, move on to HPF. Jane?
Hi, yeah, so I'll keep it brief as well. There's a couple of points in the report that could be there to look at. I think one key point was a presentation from the quality team where we discussed the implementation of the Health and Social Care Quality Engagement Act, and in particular the duty of candour, and the forum advised that support and training be made available to staff to support with that successful implementation. So the forum did offer their support in reviewing and or testing any training once developed prior to any rollout, so that offer stands. As Claire said, we have also been considering how HPF engage more broadly and more effectively with advice to the board. So we are doing also pieces of work on how we can increase the influence and accessibility, and hopefully we'll share more on that later.
Thank you, Jane. Thanks very much. So I'll move us on again to Audit. Medwin, anything from your good self?
Yeah, thank you, Mark. It's just worth noting under key risks, including mitigation actions and milestones, delays in responding to internal audit recommendations, and there's an example of one there. Also worth noting that the number of limited assurance opinions has increased this year, year on year. You can't compare like with it because they're different limited assurance reports and opinions. However, it is concerning that they've increased, and you alluded to this in your opening remarks. And in our workshop on Monday, concern was expressed around the clinical audit plan, and that despite the implications of the pandemic, this has been an ongoing problem for a number of years now. Thank you.
Did you get a satisfactory response to the last? If not, do we need to discuss it now with Nick and Jill here?
The clinical audit plan, I believe, is going to be discussed in QSC shortly.
Lucy, is that the case? Thanks, Medwin. Lucy, is that the plan?
Yes, it is. Clinical audit plan coming to the extraordinary QSC this afternoon.
Okay, and I note your observations around the limited assurance reports, Medwin, which has been subject to an exchange this week, as you would have seen too from me. Thank you. Okay, let's go to targeted intervention. Jill, we've discussed this at length already today. If you're happy, I don't propose to dwell on any of the meetings of the steering group.
That was going to be my proposal, Chair.
Okay, thank you. Thanks very much. Right, we move on to the quality and performance report. Sue Hill, over to you.
Thank you, Mark. So this is the final report for last year, and I think the report is very comprehensive in the detail that it covers. There is a section within the beginning of the report that shows the summary dashboard and the executive summary, and that seeks to describe the key areas for review. But I would like to briefly highlight the following areas, which are in line with those that have been escalated from PFIG. So just in terms of the report, in terms of quality, there were a further 2 new never events reported for Q4 of 21-22, bringing the total number of new never events reported last year to 12, which is unprecedented in terms of the last 4 years' performance. If we talk about unscheduled care, the pressures on the unscheduled care system remain incredibly high, and despite the teams working very hard, we're all aware of the situation there. But I think there has been a steady decline in performance, which is evidenced by 58% of patients only being seen within 4 hours against a target of 95%. That we had over 3,000 patients who were waiting over 12 hours in the emergency department, and we had over 1,200 who were waiting over 24 hours. I think the issues around ambulance handover delays are subject to an improvement plan, and we're working very closely with WAST around that. But we did have over 2,000 patients who'd experienced an ambulance handover delay of more than an hour. And just I'll leave strict performance until the end. But in terms of planned care, we know the impact that the COVID pandemic has had on our performance, and obviously the Omicron variant of COVID-19 continued to severely impact that during last year. And at the end of the year, we had just under 61,000 patients waiting over 36 weeks for treatment, and just over 41,000 patients waiting over 52 weeks. We have done very well in managing diagnostic waits, but we did have 6,800 patients waiting over 8 weeks. And we had about 6,500 patients who are waiting over 14 weeks for either physiotherapy or audiology. Just in terms of stroke care, which is a concern that has been raised by the committee and the board previously, and I'm sure we're going to have a discussion about it in a minute. The percentage of patients who are admitted to a stroke unit within 4 hours against a target of greater than 59%, unfortunately, we're only delivering about 16.5%. And against the target for patients being assessed by a stroke consultant within 24 hours, we are at 68% against a target of 85%. But we have mitigations and improvements against that, which are described on page 17 of the report. And I think there's been some success with the early supported discharge unit, which has been implemented in Q4. And we're also now running monthly stroke improvement meetings that are starting to work together across the network. I'd just like to highlight a couple of positive points before I guess we'll open to discussion, Chair, around childhood immunisation, where we've kept a very strong performance above the Wales average during the year. And infection prevention and control, we have seen continuous improvement around a number of different levels, particularly E. coli and C. difficile. And we had no cases of MRSA reported in the last quarter of 21-22. In terms of cancer performance, despite an increased demand on the system, we have continued to remain among the strongest performers in Wales at 70.3% for February and 70% for March 2022. And then the final thing is just around the mandatory training rate. So the Health Board is just under the 85% target at 84.9%. And I'd leave it there, and I'm happy to take any questions, Mark.
Any questions or observations from colleagues? Okay, I'll start then. And I'm conscious of the fact I don't want to duplicate the efforts and work of the committee, but there are a number of measures in here that are of great concern and which have largely been alluded to. So I'm going to start with unscheduled care and the fact that PTIC were concerned about unscheduled care. And if one looks quite simply at page 3, I don't think there's an indicator there that's going in the right direction unless someone tells me otherwise at the point at which the report was produced. That is combined with the fact that we now have YGC ED in a state of a service of serious concern identified by HIW and requiring significant improvement. So it'd be helpful to receive observations, assurances it might be provided by Joe and Jill as to actually what is being now undertaken to respond to those broad sets of concerns, not least because we've had improvement activity underway for some time, and I can't see any real evidence of impact. Jill or Joe? Joe.
Thank you, Dr. Chairman. I'll start and hand over to Jill. So just in response to the immediate actions or make it safe put in place with regard to the YGC HIW ED report, I can confirm that we have submitted all of the required immediate action plans to HIW, and that the hospital management team and all of the clinicians in ED in YGC are working diligently to implement the clinical changes and other improvements that we have put in place. None of this is, of course, to take away from the hard work and commitment of our clinical and support colleagues in ED, in YGC, but there clearly things did and have changed. As a consequence of the report, we have worked with senior clinicians to hear from them the service changes they would seek to put in place in order to improve performance. And so we have implemented a revised model of care, which is designed to ensure that patients are triaged and seen by a doctor if that's what they require within a more appropriate time frame. Although it's very early to say, because the model of care was introduced around the weekend of the 13th of May, daily data does seem to suggest that this changed model of service provision is having a positive impact, and not just relying on the hard data. A number of executive directors, including myself, have spent some time in YGC ED observing the changes in place, and I know indeed you yourself, Chair, have done the same. Although I think it's fair to say that there is more work to do to ensure that we're confident that this new model, which is called START, is going to be, at least in part, the answer to improving patient outcomes and patient experience, taken together with the other improvement aspects. We're very keen to carefully monitor outcome and results before coming to a conclusion about either accepting that this model is the right model going forward, or indeed looking at the potential to roll this model out across our other EDs. And my final comment before I hand over to Jill to talk in a little more detail about the improvement activities, although acknowledging time, is to say that the new IPC guidance that Welsh Government itself will allow us to put more hospital beds back into our system, beds which we had to remove in order to implement social distancing, and that in itself will create additional capacity in order for us to manage flow, and of course working in partnership with our colleagues in social care to ensure that the numbers of patients who are medically fit for discharge can be discharged quickly. I'll hand over very briefly to Jill just to talk about the remainder of unscheduled care improvements. Thank you.
Thank you, Jo. I think you've covered a significant amount of them there. One of the other things I'd like to add, Mark, is completely acknowledge the points that a lot of this is going in the wrong direction. We do have trajectories we've agreed with Welsh Ambulance Service as well, because we're conscious of the delays in the ED system, creating delays in the wider system for ambulances who are trying to respond to patients in our communities. And we are seeing some improvements there in terms of the handovers. Jo has alluded to the START model, and we're watching that with interest. We are seeing some early improvements, as she's alluded to, and that is the intention is then to promote that across the whole of the health board. The improvement plan that we are putting in place for YGCED, we are sharing across the whole of the health board. Also conscious as well that we need to pull in our MIUs, and conscious that because we haven't been able to staff our MIUs consistently, that has led to intermittent closures, and that does have impact in confidence in our communities, and thus they do go into our EDs. The other point I'd like to add to that is that the whole system response. So we are now, we've done quite a lot of work, particularly in YGC again, regarding ensuring that we do have beds freed up in a timely way. So we are able to support the flow through the hospitals, and working with our clinical colleagues to ensure that the subspecialties are responding to the front door of our ED. So if a patient is referred to a surgical colleague, for example, that they are seen by a senior doctor in a timely way to enable us to see quick flow through the ED. Much of this is being reinforced, Mark, and just today a few of us have a meeting with the HMT in YGC to see progress against their own plan, but the intention is to do that across the whole system. It is worth noting that we still do have 321 patients medically fit for discharge across our organisation, which brings its own challenges. So the response on a whole system is really critical moving forward, and Joe's alluded to the work that's being coordinated by Welsh Government around how we can access some capacity out with the acute facilities.
Right, thanks both. The next topic, and then with regard to what John said from PTIC, is planned care. The performance, and I realise the impact of COVID continues to be somewhat problematic. Moreover, if one looks at the operating plan monitoring report, and again, I realise the impact of COVID, there must clearly be a correlation between concerns around performance, which is not improving in some key respects, and the fact that 29 out of the 87 actions that were agreed in last year's plan are shown as red. So observations, Joe and Jill, as to where we now are in terms of planned care and what the scope is in terms of seeing improvement in that regard, please.
Again, I'll start and hand over to Jill. So the same Welsh Government guidance with regard to social distancing, which would have a positive impact on bed numbers, also applies to our capability and capacity to improve the volumes of planned care we can provide within our existing estate. So COVID restrictions have meant that the number of procedures per theatre have had to be reduced. For example, the number of chest x-rays and other x-rays have had to be reduced whilst we deal with issues around social distancing, both within waiting rooms and with regard to the use of equipment, and the same goes for outpatients. We will be in a position to largely reinstate our pre-COVID arrangements, with some agreed exceptions for clinical purposes. So simply being able to put that capacity back in will enable us to increase our throughput and thus start to work to reduce our waiting times. The board has previously approved a number of outsourcing arrangements which have enabled us to continue to provide outpatient operations for patients who have been selected from across North Wales, long waiters who have been supported to travel to receive their eye and joint operations. Those arrangements will obviously continue, and as part of the agreed IMTP investments, we will be seeking to increase, for both insourcing and outsourcing, the range of alternative provision that we can provide. I'll hand over to Jill to talk about some of the service transformations that we're doing, which will include streamlining some of our outpatient contacts and thinking about working with different clinical professionals in order to expedite earlier treatment. Thank you.
Thanks, Joe.
So just to add to what Joe has described, I think there's a number of other actions that we're taking place, learning from some of the getting it right first time transformational people, getting it right first time best practice mechanisms that have been shared with us, Mark, and we are seeing already really good engagement within our orthopaedic pathways, to ensure that we can maximise the capacity we have, and that does include increasing capacity for new outpatients, as well as increasing capacity through our regular lists. And of course, whilst getting it right first time is initially we are taking forward within orthopaedics. It's not the only specialty that we'll be taking it forward with, as it includes urology, general surgery, gynecology, and ophthalmology, amongst others. So there's a lot of work going on to ensure that we are utilising best practice, and that is being supported and led by our clinical leads as well as the operational teams. I think the other point I would make, Mark, is Joe's alluded to the changes in the guidance that will impact our outpatient departments as well as our diagnostic departments. There's a positivity there, but there is also a recognition that we need to again increase our virtual platform, because we know that has been well received by a proportion of our population. The final point I would make is that we are working with the teams, wherever they may be, to do a confirm and challenge across their capacity, and to monitor, put strong mechanisms in place to monitor any variations from the expected activity, so we can have early intervention. So I mean, that is where we are currently. Clearly we will be reporting through PFIG, and we will be working closely with the delivery unit, as indeed we have been, to ensure that our plans are robust and we're able to have supportive governance in place to ensure we remain on trajectory, recognising, as I say, that the changes that have been alluded to will support us getting more to a more normalised position.
Okay, so before I come off plan care, then a couple of other things from me. We don't have this information in front of us, but were you to look at the weekly performance report, which was issued this week, diagnostic weights has lapsed considerably and is at the highest point in the last year in terms of radiology, and indeed the waiting list has lapsed by just short of 1,000 patients. Do we know why that is?
So, Mark, I've asked for a deep dive in diagnostics to understand why we've seen that increase. So I'm happy to come back to you outside. It's already taking place, Mark, so it shouldn't take long to get that explanation.
Right, can that be reported?
Sorry, forgive me. I think that relates back to the enhancement in governments we put around reporting.
Mark, if I may just add, I spent some time at the Alex last week and spoke actually with some of the imaging staff who were able to speak very eloquently about the impact of the limitations of social distancing on their ability to work through patients in a timely manner. I don't think that this will necessarily be all of the answer, but listening to them and their experience, I am confident that the release of restrictions will enable them to go back to what was their normal average waiting time for a GP referral, which was in a matter of days or weeks, rather than where we are at the moment, which is closer to months. So some small light on the horizon, as discussed between myself and one of the radiographers at the Alex. Thank you.
Okay, thanks both. So can we have a report back on that, please, particularly around radiology, given the leap? And then finally, in terms of plan care, Gareth, I know we've discussed this before, but if you look at page 3, therapy weights seems to be on an inexorable rise, and shows no sign of abating. What's your view on that? And do you anticipate we're going to start to see a reversal, and if so, when?
Yes, thank you, Chair. Yes, to answer the first question, I expect to see an improvement in the weights. I think the data for the end of April show the position has stabilised, possibly decreased slightly. The explanation for the weights is almost exclusively around the physiotherapy service, which is the grey element of the bar, and specifically physiotherapy east and physiotherapy central area. The issues relate really to three things: physical space, which in particular in the east has been a problem since the first wave of COVID, and we haven't been able to replace all the capacity yet. Staffing, central and east have seen some recruitment problems over the last 6 to 8 months, which haven't been fully mitigated yet. And equally, as we're doing more planned care within the organisation, in particular orthopaedics, demand has increased as well for physiotherapy. What is going on? The clinical director of therapies has detailed plans now for all the services. He is working with the delivery unit around those plans to ensure that we are able to deliver against the Welsh Government targets. And perhaps more positively, we've acquired additional physical capacity in the east that will come online from June, and that will take us through to the permanent solution for the physical space issue in the east, which is in the Plasgarorau facility that we are developing over in Wrexham.
Thanks, Gareth. Okay, 3 more areas I want to cover. First is stroke, highlighted by Petrie, revealed in this document as being an area of concern. Who wants to respond on behalf of the executive team in terms of stroke? We are aware, of course, we approved the business case and investment. Joe and I have visited stroke unit, particularly in the West. There was some positivity around the investment, particularly in terms of rehab. But Jill, then you put your camera on.
Yes, if I may, Mark, and yourself and I also obviously met with the team in YGC. There has been some conversations and actions taken place recently, Mark, following our conversations to ensure that our stroke beds are protected across the whole of the sites. Because of the unscheduled care pressures we've had, unfortunately, at times those beds have been used by other unscheduled care patients. So we are now protecting those. We've understand the impact that's having. We're working with the teams, and Mark, I think you're part of the conversation to enable the teams to fast track those patients through the ED and look at best practice elsewhere. There is an improvement group meeting, I think within the next 2 weeks, Mark, where I'm anticipated that we've got clear trajectories against improvements on those. And I've got a second meeting arranged with the new lead for the stroke improvement as Rob steps back, and the improvement, the network lead, to agree those measures so that we can report back on them. And critically, this is about getting this patient to through the system as quickly as possible and be able to respond. So it does link back in part, Mark, to our unscheduled care.
Okay, 2 more areas then. The first is Sue, sickness, reference to sickness increases, and also Warren Lee, an average of 14% across the staff groups in primary care, absent on sick leave in Q4 of the last performance year. Observations, Sue, from you in terms of sickness?
Yeah, so some of this we have anticipated, and again, we're not an outlier across Wales. One of the significant increases over the Q4 was around our COVID, and particularly Omicron. So we previously reported quite considerable absences, either directly or indirectly related to COVID. However, we are seeing, and we believe we will continue to see, increases, particularly in stress-related absences, both indirect and direct. We've further augmented our staff wellbeing and support services, and you'll see in the IMTP there is a priority in there to embed that on a sustainable basis. So there is a as a case with me, ready to go through our governance structure for embedding the staff wellbeing and support service across the organisation. That's not only a service that treats staff, but it is a service that then really builds the capacity and capability across our organisation to see psychological well-being as a primary form of leadership role. So that coaching, the SWORCH rounds, the service for colleagues who require services, but also developing the capacity of our managers in the future to deal with this at an earlier stage. So we're anticipating seeing further increases, but we have strategies in place to try and address that and try and ameliorate the impact of what is being seen across the UK.
Okay, I've asked previously not to use Sue about primary care resilience, Joe, and where we stand and what the plans are. I've still not seen a comprehensive response to that. Can we see one at some point soon, please? Given the rate and the other issues that we know we got in primary care.
Yes, I'll work with you offline to work through a governance route for that. Thank you, Chair.
Thank you. And then finally, Sue, there's reference in here to recruitment in support of the business case that we agreed for our emergency departments, bearing in mind the conversation we just had about performance and YGC in particular. There's reference to that for recruitment progressing. Are you tracking that, Sue, and are you content it's progressing? And then there's reference to the continued struggles that we have around recruitment of ED consultants. Anything you can offer by way of update in that regard, please, briefly?
Yes, so we are tracking it, and now we've got the EDG running up and running more smoothly. We'll be also tracking it through the EDG. In terms of consultant recruitment, we've had a number of discussions over the last few weeks, particularly around looking at alternative methods, both of attraction, using some of the campaign work that has been very successful in some of our other services, for example, CAMS, but also looking at alternative roles that could then release the consultants that we have to work differently. So those discussions have been underway, and the teams, the operational teams, clinical teams, and my team are working through a proposal to come back to Jill, Nick, and I and Gaynor over the next, I think it's week to 10 days. But we are tracking that and identifying whether we're seeing any barriers.
Okay, thank you. And then finally, Joe, not a question, but to note, I think that you, Jill, and Nick have been reviewing 2 service areas and the approach to improvement. And I think they are urology and ophthalmology. And from my conversation with Welsh Government, you've had a conversation with them in that regard too. Is that right? And should we note that?
It's accurate.
Joe?
Yes, that is correct. And yes, it's appropriate to note the conversations that Jill, Nick and I had with Welsh Government representatives yesterday, and to note that we have agreed to exchange correspondence with Welsh Government on both matters. We will ensure that correspondence is routed through you, Chairman, as it's linked to a previous request from the Minister. Thank you.
Thanks, Joe. Right, Claire and then Cheryl.
Thanks, Chair. I am struggling with my camera today. I do apologise. I guess it's what I struggle with this report, because it covers so many areas and there are so many reds. It's really difficult, actually, I think, to pinpoint the critical things that I really need to understand better. So I guess I've just got a couple of general points about the targets themselves that we'd set for ourselves for the year that's just finished. And I'm assuming that they were set in the context of being 1 year into COVID. So that's a general question. A number of them I know are national targets. And I guess it's perhaps not for now in the board, maybe outside of the board, I'd appreciate a much broader understanding of how we were performing 2 years ago, pre-COVID, how our current performance compares to that, and what the trajectory for being better than we were pre-COVID, but at least getting back to what we were pre-COVID, what that would be, and what the impact of that is around critical areas and critical services. Because it is almost, you can get focused so much on a red without understanding, was the target realistic? Did we have a good plan in place to meet it? And what we can expect in terms of our improvement trajectory now to get things back to as good as, but better than in many areas than they were pre-COVID. So I'm really not expecting a full answer to that now, but outside of board. Thank you.
Claire, I suggest we return to that observation and conversation after we see the revised performance report, which is coming to board in July, which may assist also in terms of its construct, in terms of what it covers, but also how it covers it. So I know that Joe and I have been speaking to Amanda, the performance lead, around being clearer in terms of the use of statistical significance, so that we avoid knee jerking around, for want of a better description, on peaks and troughs, and better understand the trends and what's significant over time. So I anticipate, and I'm sure Joe is too, that is going to be more clearly built into the report. So I suggest we return to that once we see the new report, if that's okay with you. Thank you. Sue Hill, then Cheryl.
Hi, Chair. I just wanted to say I'm very happy to meet with Claire outside of the board just to take you through the performance reports and the plans that we have, because I'm conscious that it's been quite a select subset of the IMs who have been part of that journey, but we are hoping to take the report to a board workshop in the near future.
Yeah, great. Thanks for the offer. I'm so sure Claire will welcome that. I'll leave that to you to arrange. Cheryl.
Thank you very much, Chair. Yes, just two quick questions. One is around, is the particular delays with suspected urological and breast cancer, given some of the concerns that have come back to me in the last few days from the community? That's my first question. And my second question around the urgent reviews of eye care issues at Abergele Hospital. When people are ringing, they're still being told it's up to 2 years for an urgent review. I would like we could answer that outside of here. Thank you very much. I understand we have time constraints.
I can start an answer from the ophthalmology, Chair. I'm happy to take it outside as well, but we are currently doing a piece of work to we already prioritise, as you know, but I've requested that we work with clinical teams to reprioritise and see what we can do to utilise different parts of the pathway, if you like, to bring those times down. But I acknowledge what you've just said regarding the information that you've been given, so perhaps we can take that outside. With regard to the urology and the breast cancer, just should have alluded to it earlier, but we've got our first meeting of the Cancer Partnership Group, where we intend to address any inequalities across the whole of North Wales for any of the services, and that the first one of those groups starts this month. It commences this month, and it will be we will be in shadow form with the or buddying up, for want of a better term, with the Manchester Cancer Board to learn from the significant progress that they've made as a consequence of the changes in the way that they manage the services. So we'll be working alongside them.
Thank you for that, Jill. That's reassuring to hear, because that links into my previous issue about the GPs not being open. These cases seem to be coming thick and fast now, given the last 2 years that we've had through no fault of anyone's. But I'm very, very concerned about those particular areas of the cancer figures. Thank you.
Thanks, both. Okay, if colleagues are happy, Warren, stop the exchange on the performance and quality report there. And we'll move to the operational plan monitoring report. Having just had the exchange that we've had around performance, and bearing in mind that we now have a new plan with new priorities and actions for this current year, I'll look to limit the discussion here if I can, but start by seeking assurance from Chris and Sue that any outstanding actions that remain apposite in terms of how we move forward and improvement are being rolled across or have been rolled across into the new planning framework. And Chris, you and I had an exchange on that point this week. So do you want to respond?
Yeah, thank you, Chair. Very happy to. It's easy to respond really to say yes, everything that hasn't completed this year, with the exception I think of about a couple which are being retired but will be explained, are being rolled over, and the new reports which will come through, we'll have those listed alongside the new items for reporting in this current year.
Okay, thank you. Right, any questions or observations around the report, please? Lucy.
Thank you, Chair. Just a point of accuracy, if I may, the report refers to the fact that it's been to QSE committee in May, and it hasn't. I very much want the format that we'll be receiving in July, though. Thank you.
Thanks, Lucy. And there is a new format coming in July, which I had the opportunity to look at with Joe. But Lucy, while you're on the mic, for want of a better description, and Teresa, the other area of significance in terms of the number of actions shown in red is mental health. Are you, Lucy and Teresa, happy with the current state of affairs and content that the actions that have not been delivered either did not need to be delivered or could not be delivered at this point, or are to be progressed in the new performance financial year? Lucy. Or Teresa or Lucy, I don't know which goes first. Teresa, you go first. There you go.
I'll speak in English to this one with Lucy. From my perspective, I've asked the team to review all those actions. I think we were over ambitious as a team. The team acknowledged that, and some of the issues relate to workforce and vacancies. And actually we have significant vacancies where we are out to advert that we at the moment are struggling to recruit to. And certainly that was the case with some of these programmes of work. So we have introduced into our schemes for funding or any new funding going forward, a doability factor to make sure that we're not over ambitious and that we maintain that focus on delivery. So that's in place going forward, and we're reviewing previous schemes. So I'm not content that we've not delivered, because they were all there for a reason. So for me, it's prioritising, regrouping as a team and asking the team to work slightly differently. I'm also content from a workforce perspective that we're hoping to learn from the CAMS recruitment work as well, and that might help pay dividends for adult mental health going forward too. So I'm looking forward to those discussions.
Lucy, anything you want to add?
Yes, thanks. I agree with Teresa. I understand the reason why a lot of these have not been delivered. My biggest concern in terms of progress, to be honest with you, is actually the psychological therapies. However, I've met with Gareth Evans about that piece of work, and that's partly linked in with the operating model as well. But we did receive an update at May's QSE committee in relation to that part of the service, and I'm content that under Gareth's leadership that's now being starting to move forward, but there have been various reasons why it's been held up.
Okay, thanks, Lucy. Sue Hill.
Thank you, Chair. I just wanted to comment on the work we have done during the year to improve the performance reporting for next year. And I just wanted to thank the performance and business intelligence teams who have done an awful lot of work to redesign the two reports going forward. And that has been based on the very constructive feedback that we've had and contributions from the chairs of our three subcommittees. So Lucy Reid, Linda Thomas and John Cunliffe have really put in a lot of time and effort working with us in several meetings and workshops that has allowed us to sort of move forward and progress with the project. So I just wanted to, note that.
It is noted. Okay, thanks, Sue. we are going to move on then, if I may, to the next item. Sue, that is your end of the year finance report that's been circulated. Over to you, Sue.
Thank you, Chair. So this is the unaudited financial performance for the full year. We have delivered a very small surplus, 0.3 million, which is about 0.02% of our allocation. And I think just the highlights are the draft accounts were submitted to Welsh Government on the 29th of April, and Audit Wales are currently in the process of auditing those accounts. And that is due for completion at the beginning of next month. We're asking that the board delegate authority to the audit committee to approve the annual accounts and returns at the meeting on the 13th of June. But I think just in terms of the highlights of the report, there is a balanced scorecard on page 4 of the report, which shows a very positive performance for the Health Board. I think it's generally a green performance. In terms of our statutory duties, we have, on the draft accounts, we have broken even, we have achieved our cash balance, we have achieved our capital resource limit at 45.4 million. And we also delivered on the non-NHS invoice target of 95%. I think the highlights are around the savings programme. So we delivered 19.2 million in the year against a plan of 17. The unfortunate element is that the recurrent percentage was only 52% at 8.9 million, but we did overachieve against our target. And it's worth noting that COVID-19 costs in year were 101.9 million. This was fully funded by Welsh Government, so had no impact on the position. But within that number, we spent about 15 million on test and trace and a further 17 million on the vaccination programmes. It was still a considerable number, and that just reflects, I guess, the fact that COVID-19 hasn't gone away, although the vaccination programme has been an incredible success. And I think there's just a couple of points that I'd like to discuss around the pay element of the report. So I think if we look at the variable pay, it's 124.5 million against a total of about 913 million spend in year. So that's 13.6%. And if you just look at agency and locum costs, that's about £71 million, which is 7.8%. So obviously, it just shows the importance of Sue's people strategy, workforce strategy, and how we go forward with the operating model in terms. I think I would leave it there, Chair, unless there are any specific questions.
Okay, anything from John C. or Richard from PFIG?
Nothing specific, Mark. Everything that we picked up through going through the report was in my chair's assurance report anyway. But I think Sue's highlighted the areas of concern around the savings delivery.
Okay, thank you. Thanks, Sue. I'm going to move us on then, and we'll go to the vascular services report. Nick.
Thank you, Chair. Can I first apologise to the board because the standard paper giving an update from Vascular Steering Group and QSE is not part of these papers, but is written, and I'm very happy to share that outside the meeting and ensure that it is published appropriately. What is in front of you is a copy of an exec paper which led to an exec approval last week that the additional measures that have been put in to provide enhanced safety to the vascular network between the 17th of March and the 23rd of May, a decision was made last week that they could be refined. And whilst the MDT decision, enhanced MDT cover and enhanced governance around the service will remain in place for the foreseeable future, the double operating for all procedures and the double consultant on call measures that were put in place will be stood down, and indeed have been stood down from the 24th of May. I'd like to really thank consultant colleagues for that cover, because that was an incredible commitment and well delivered. But I think it became evident that despite that huge commitment, really it didn't lead to any enhancements in safety, and therefore I'm absolutely confident that the decision made by the executive team is the right one. We will, of course, Chair, continue to keep that decision under very close review, and there is a weekly process to ensure that we do that. So very happy to take any questions, Chair.
Any questions? No. Okay. We ought to note too, and John wants to come in, but I'll come to in a moment, Nick, that there's an update going to the Ministers today too, as requested by her, with some more detail around our actions locally. Okay, thank you, Nick. John, G.
Thanks, Nick, for the update. Just a couple of points, if I may, with regard to how we're working with Liverpool at the moment, and the fact that that is clearly having an oversight. Within the report, it makes reference to more complex cases being referred to Liverpool. I just wonder, from a practical point, the current consultants that we have working within the vascular service, they are the ones that are making that judgment call, but would they not normally be conducting those types of operations? So it's the question really is around, they're making a judgment around their own workability and how that then feeds into what goes through to Liverpool. The other one, welcome the aspect around the planned programme of recovery, and you're saying around how the original 28 days has now been extended to cover that. But one of the key points, I suppose, is around, from a timeline point of view, and I appreciate there are lots of factors taking place here, but when do you feel that we may well be heading in a direction that this particular service is no longer a service of concern? Thanks.
Thank you, John. So in relation to the procedures being carried out within Liverpool, this has always been the case, and indeed, in any vascular network, there will be regional tertiary centres, particular centres of excellence, where some of the more specialised procedures are carried out. Those guidelines are very much laid out nationally, and the Vascular Society reviewed and published those at the end of last year, beginning of this. The decision as to which patients would benefit from that extra specialist cover is not made purely by our consultants. That's part of the enhanced MDT measures, the enhanced support with Liverpool, where they work with us, they challenge us, they work with our teams to make sure that we are making the right decisions. And I am getting increased, and we've had a great deal of confidence and reassurance that in fact our decision making has been entirely appropriate. During the period from mid-March through to May, the MDT decision made by our own teams was never challenged by Liverpool, and indeed we never made a decision to transport to operate locally when it was felt that it would be more appropriate for a patient to be seen in Liverpool. And whilst we will continue to review that, that obviously gives us a great deal of reassurance. Had we seen the full report, John, we would have seen that we've had some successful recruitment over the last few weeks since the last board meeting, which is, I really welcome, and I look forward to those individuals joining the health board later this year. And I think until we see that sustained recruitment in place, John, I think we will always continue to see the vascular network as one that needs particular care and attention. But in my time in the health board, the 8 months, as it now is, 8-9 months, I think I have seen far more effective multidisciplinary working and professional behaviours, but there is still a lot of work to do. Thank you.
Thanks, Nick.
Thanks, Nick. Lucy.
Thank you, Chair. Nick and I have discussed the vascular service and the improvement plans and what's going on within it in great detail. So, you know, beyond this report, we've had very detailed discussions on the progress against that. And I also met with the chair of our independent chair of the quality, the vascular quality panel as well. I'm very content that the extremely thorough piece of work that she is facilitating will inform us as to the really detailed actions that we need to take as we go further into the improvements of the service, and will be fit for purpose. As you know, Nick, she's providing you, isn't she, with a weekly report. She's going to copy me into that as well. And so we're not waiting for her to finish that piece of work. It's she's actually reporting what needs to be done in the meantime in her initial findings. In terms then of the improvement plan as well, I just wanted to point out to everyone on the board that we've got a separate vascular plan at the moment and a separate emergency department plan. Of course, what's going to be talked about this afternoon in the extraordinary QSE committee meeting is an overall YGC improvement plan, which will incorporate both the vascular and the emergency department actions. So we're not going to be looking at this in isolation. It's going to be looking at the whole system. And that's what we're picking up in this afternoon's meetings, is how exactly that's going to be approached, so that we've got a whole system perspective rather than looking at individual sections.
Thanks, Lucy. Any other observations? No? Okay, thanks, Nick. I'm going to move us on to the next item on the agenda. That is the Quality Highlight Report. Gaynor.
Thank you, Chair. I've asked Matt to come and present this paper because it's a period of time before I'd actually started, but I am absolutely happy to support any questions afterwards.
Yeah, Gaynor. Matt.
Good afternoon, thank you. Just picking up, if I may, the key points to raise from this report. Before I do, due to the sequencing of the meeting, most of the information here has already been through the QSE committee at its last meeting. I think the main things I want to draw the board's attention to is the position around nationally reportable incidents, which we would formerly have called serious incidents. We reported 42 of those, including 3 never events in the February to March period, and this represents a higher average position than what we've seen over the last 12 months. And indeed, it is a higher rate than what is seen in Wales, and I think could indicate a deteriorating position. A number of those incidents relate to, I think, a small number of groupings of incidents. So falls that result in severe harm to patients continues to be our highest prevalence of serious incidents that we report, followed by grade 3, grade 4 or ungradable healthcare acquired pressure ulcers. We've also, and that's been the pattern we've seen for some time, we've seen an emerging theme around the recognition and care and response to patients who deteriorate in our care. And as the board will see, we reported a number of incidents that fall into that category. I'll pick up never events in a few minutes, if I may. So in relation to those areas, the paper details some of the work that's being undertaken in response to that. And the QSE committee had a detailed paper around falls and pressure ulcers at a recent meeting. We're also taking forward, as part of the new transformation and improvement approach, there will be a safety programme, and executive colleagues met and discussed what should be the priorities for those, and falls, deteriorating patient and healthcare required pressure ulcers will be 3 of the main priorities, and there's a paper being drafted that will go through to the executive team shortly around that. The predominance of never events, and I think this may have been touched on earlier in the performance report, continues to be around surgical safety. So we reported 3 in the last 2-month period. However, that actually brings the total for the last financial year to 12 never events, of which 11 of those were surgical safety and 7 of the 12 were at YGC. And I think that highlights where we have a particular area requiring focus. The paper describes some of the work underway in relation to that. So for example, we have, again, through the Transformation and Improvement team, a Quality Improvement Clinical Fellow who is currently working with theatres at YGC to review and improve surgical safety practices, particularly around issues such as the HU surgical safety checklist. And that's intended to expand to the other sites over time. We've also commissioned an external specialist organisation to help us build our capacity and capability around human factors. The intention is that we're going to do some human factors based work, again in YGC, rolling out to the other sites. But that service will be providing some long-term support for us to develop that capacity internally. And the first cohort of training commences tomorrow in relation to that. So that's probably all I would mention around incidents and never events. If I move on to some of the other aspects, complaints, if I may just draw attention to that, the number of complaints has increased in the last few months, but that reflects a reduction we actually saw over the winter. So I think there's a catching up, if I can use that language. We continue to progress many of these as early resolutions and resolve them satisfactorily. Of the complaints, though, we do have a challenge at the moment in terms of the number overdue and the response time to complaints. Services report that's due to clinical and operational pressures. We've worked with all services to develop recovery and improvement plans around their position, but that does continue to be a challenge for us. And that does mean that potentially patients, carers, families are waiting too long for responses to their complaints. The work we're doing is very much trying to focus on immediate learning, immediate make safes, but that is an area that does require some focus for us. The other aspect I draw attention to, we've included some high-level patient feedback responses in this report for the first time. We received just short of 2,000 patient feedback responses in the last 2-month period, and I've included the details there. I've also included the details of where we have some improvements to make, including one of our worst performing patient feedback areas, which is the ability to speak Welsh if patients so choose to do so. And that is just over 43% reported positively on that. The PALS team continued to support patients. We had just under 1,000 inquiries over the last 2 months. The main themes continue to be communication between services and patients, or particularly relatives communicating into relatives within hospitals. I've itemised here one Regulation 28 prevention of future deaths notice that we received. Excuse me, it was in May, although the inquest actually related to February. There was a delay in that being issued to us, and that relates to some medication safety practices in community nursing. The response to that is due back with me today, actually, and the service has been working hard to put together an action plan as to what's going to be done in relation to improving practice around that. However, it would be remiss of me not to mention that since this report was written, we received 2 further Regulation 28 notices, one recently around the length of time taken to implement an action to improve administrative processes, and the second in relation to ambulance handover delays. And finally, I would just highlight, before I conclude, the HIW activity, of which there was an inspection to one of the mental health wards at Brennan Air Hospital, which was a relatively positive inspection, but we also had a number of inspections to the emergency department at Ysbyty Gwynedd, and 2 inspection visits, one remote to Ysbyty Gang Clwyd. I'm sure the board cited on those, but there is a detailed discussion around the YGC action at the QSE meeting that's following later today. That's probably the main items I would highlight, Mr. Chairman. Happy to take any questions.
Okay, before I open it up, Lucy, as chair of QSE, is there anything you want to say by way of opening?
Thank you, Chair. There's yes, first of all, I very much welcome the work of ACCL coming in, because we still have a lot of work to do in relation to learning from these incidents. As Matthew has already highlighted, we're seeing an increased number of never events around surgical safety, which The recurring themes show that whatever we've been trying to do to address these clearly hasn't been embedded in a sustainable way. I have got a couple of questions, actually. If it's okay with you, Chair, I'll ask those before we then move to the others.
Sure. Yeah. Thank you, Lucy.
Thank you. First of all, there's reference at the beginning of on page 6, Matthew and Gaynor, about a review of the acute intervention team, which is being led by the Deputy Director of Nursing. Do you have any timescales for this, please? And does it take into account the concerns raised recently about the redeployment of that team in Ysbyty Gwynedd? And then secondly, in terms of the Never events themselves, on page 8, we've got 2 wrong site surgery ones here. The first one talks about the surgeon being new. There's an emphasis being placed here on immediate learning, that the surgeon was new to the health board. And I'm not quite clear why the emphasis has been placed on that. And secondly, the second wrong site surgery, I'm not sure why we haven't got actually a description of exactly what happened here. But again, the second one in relation to the transfer to Stoke, again, my understanding on this when we discussed this at QSE committee was that the immediate learning wasn't about the decision making to transfer the patient. So I think a little bit more detail on what exactly has been captured as learning would be helpful. Thank you.
Thank you, Lucy. Sorry, I was just getting off mute there. I think on the first point, I know that Mandy has completed the baseline assessment and is working on pulling together a plan for that. I don't have a date off the top of my head or in my notes for that, Lucy, but I'm happy to speak to Mandy and get that information provided to you straight after the meeting. In relation to the Never events, so there's certainly not an intention to make the emphasis around the staff member being new, and apologies if that's come across. I think where that's originated from is the member of staff, I think being relatively new, perhaps hadn't been inducted fully into all of the ways of working, didn't have necessarily all of the right IT access permission set up, and didn't necessarily have all of the training to access some of the systems that they may want to access. And in terms of looking at the sequence of events that contributed to that incident, those I think are part of that sequence. They're not solely accountable, but they are part of that sequence. So that's the element that we were getting to there, perhaps around the surgeon being relatively new to the organisation. And then on your final point around that other Never event that we've mentioned, I think we took some of the detail out to try not to make some of these incidents identifiable to individuals, and I think there's always a balance there to be struck. The element around decision making around the transfer was whether the patient should have been airlifted to Stoke immediately, or whether being brought to YG and then an onward transfer to Stoke. So that was the element that was being given to consideration, and the hospital medical director was leading a review of that part of the investigation, just to make sure that that decision making process was correct, or whether there's any learning that could be taken forward in relation to that.
Thanks, Matt, for that additional detail and information. John C.
Thanks, Mark. Thanks, Matt. I think Lucy's touched on one of the areas that I was thinking about in terms of this report, which is in terms of the learning from the investigations as they concluded. And I just wondered whether we need to go a bit further back because of the commonality between some of the Never events. How far have we gone back in terms of analysis of those common failures, to be able to understand whether learning is being applied properly? But the other area that just struck me was the report, particularly on page 5, talks about overall closure rate as reduced. But what made me then think is in terms of, well, how many serious incidents or never events are still open, and how long is the oldest been open? Because I'm just worried about whether the right level of urgency is being applied to some of these to be able to then close them off, understand the learning and apply that learning.
Yeah, thank you, John. So in relation to the questions, we have done a thematic review of all never events going back 3 years. And we originally completed that piece of work for June of last year, and we've recently reviewed that within the last few months to take into account the most recent never events over the preceding 9 months. So that piece of work has been done by our patient safety team to make sure that we're pulling out all of the key themes around that. And your second point around the investigation. So I don't have that information immediately available, but it is available. We do track that information. We want to have as many investigations completed as soon as we can. We set a target of either 30 or 60 days, depending on the severity of the investigation, the complexity of the investigation. So we monitor the closure rate to ensure that we're getting timely learning. And also we're very mindful that in certain cases, any delays to our processes internally might impact on things like the coronial process that we want to avoid. So that's why we monitor that. There are around 22 overdue investigations at the moment, so I can give you that information, and we're working with services to address that. It is primarily YGC and YG where we're seeing those overdue positions. The rest of the divisions don't have any notable item to escalate. So I'm happy to get you that more detailed breakdown, John, if that would help outside the meeting. I just don't have that to hand with me now.
Yes, thank you. I think the bit more detail will be helpful. It's that element of urgency as well. Is if there are issues in terms of closing things out and they're overdue. Now, the worry is that they go on a very long time. You get too much distance from when the incidents occurred, and you're not be able to understand or do that sort of root cause analysis to be able to apply corrective actions as you go forward. But thanks.
Absolutely, yeah, thank you. My expectation is that although we've hit some challenges over the winter period, that we move back as quickly as we can to complete an investigation in that 30 or 60 day time frame, which is ample time to do that. So that is a real effort, a real focus of our efforts.
Okay, Jill, did you want to come in on this subject? I see your hands raised.
Yeah, sorry, I did want to come in on. Sorry, was it me or did you say Jill?
No, it's you. I
Okay.
just saw the initials. Thanks.
Sorry, I don't know how to put my name on it. I'll have to have a technical lesson. Apologies, Mark. Yeah, I wanted to come in this because this is going to form part of the work that we're going to be talking about in the QSC about the improvement plans, because one of the things that we have discussed is this ongoing learning and then making sure that things are embedded. So the never events, the serious incidents and everything will be captured in improvement plans because they should be overall improvement plans. Happy to discuss it further. We are talking about it later in the QSC, and I've also got a session with Nick, Chris and Gareth later today to talk about how to embed it.
Thank you, Gaynor. Thanks. Okay, I'm going to move us on to Cheryl next, please.
Thanks very much, Chair. Lucy and Gaynor have touched on my first point, which is around the learning events and making sure we embed those in. My second was a question to Matt. In these figures, have we included the recent the March YGCED inspection? Are the figures included? I'm looking particularly in the one delay or failure to monitor patients. Have they been included in this? Thank you very much.
Yes, Cheryl, I can confirm that the information in here is the full month position for both February and March.
But with those added retrospectively, yeah?
That's right, yes, absolutely.
Thank you very much, Matt.
Cheryl, Sue Green.
Thanks, Chair. So I wanted to highlight, mindful that it's not contained in the report, but it is relevant, and colleagues are working together to ensure that this is included in the report in future. In relation to falls, the board will be aware that following the inspection in November of 2021, the Health Board was issued with an improvement notice and notice of contravention in relation to our patient harm from falls. We submitted evidence to the Health and Safety Executive on the work that had been done, and the Health and Safety Executive came back into the organisation to validate that we had done what we'd said we'd done on the 18th of May. They have therefore concluded that those notices have been closed. So that has moved forward, which is a good thing. Nevertheless, there is still significant work required to improve our safety in relation to reducing harm from falls. Secondly, I just wanted to highlight to the board formally that we have received notice of contravention from the Health and Safety Executive in relation to the tragic death of a patient in the Hergest unit in 2021. We are clearly working with the team and with Gainer's team, and as well as mine, to formulate appropriate actions, not a separate plan, but very clearly as part of the overarching improvement plan, but very specific actions required for the Health and Safety Executive in that regard. Just wanted to highlight those as they're not contained within the report. Thank you.
Thanks, Sue. John G.
Yeah, thanks, Chair. Thanks, Matt. Just a couple of points, if I may. Particular reference to the delays in responding to some of the incidents and some of the complaints, etc. It would appear that there's possibly a capacity issue within the team. But if I can take particular reference to the Ombudsman, where there's 84 open cases, 42 in 2 months, do we have any information at all around how many of the cases referred to the Ombudsman are actually as a direct result of BCU not responding to the complainant within an appropriate time? So they actually see that as the only course of action with regard to trying to get any resolution. And then just the second point is specifically around the Welsh risk pool and the financial implications going forward, not just for BCU, but all health boards. There's obviously a significant number of claims that are being processed across Wales at the moment. My understanding is that we currently pay the first 25,000 of any potential claim. But going forward, in view of the high value of some of these claims, is there a financial risk coming back to the board where our contribution is going to be increased beyond the 25k? And if so, have we actually taken that into account within our financial budgeting going forward for this year? Thanks.
Thank you, John. Yes, so we do have that information around the Ombudsman inquiries. The numbers referenced here will be a mixture of what are called inquiries by the Ombudsman, which could just be matters that they're wishing to follow up, or it could be, as you say, matters where a patient, care or family member has gone to the Ombudsman because they haven't had our response. And then it will also include investigations as well. I don't believe we get that many cases where patients will approach the Ombudsman chasing for response, but we do have a few. I can certainly think of a couple that have been brought to my attention in the last few weeks. So that will be part of that number, although I don't believe it's significant. Mostly patients will come to us and express their dissatisfaction at the length of time that it takes us to respond. We do try and keep patients informed of response dates, but sometimes, again, we're dependent on the services being able to give us accurate dates as to when they're able to complete those investigations. We currently have around 300 overdue complaints, which is an unacceptably high number, and we really need to take action to address that. Again, we should be responding to 75% of complaints within 30 working days. So there's a clear KPI for us to work to, and we do need to address that. I think we have enough capacity to respond to complaints But where I think the challenge is coming from is that because we have a number that have been built up to that 300 number that I just mentioned, I think services are struggling to address that and address complaints that are coming through at this moment in time as well. And that's where I think we need to be focusing our efforts. As I say, we've asked all services to develop recovery plans and trajectories, and we continue to work with them to try and get those to respond to as soon as we can. And my hope is that we will see improvement in the next few months around that. On the second point of claims, I don't believe that we will be in a position where we'll be asked to contribute more than the 25,000, but the cost of litigation is rising across the NHS, not just in Wales, but across the UK certainly. And we pay an amount into the Welsh Risk Pool each year, which is a risk pooling scheme, and there is a very real risk. In fact, I think it is a certainty that there'll be an expectation that the cost that we pay into that risk pool overall membership scheme will increase. Sue may have a more detailed position than me on that point, though.
Thanks for that.
So that last point then, do we have further information? Sue Hill, is it something that's within your knowledge, or Jill? Because obviously that will create a cost pressure, let alone anything else that we presumably haven't accommodated yet.
Yeah, thank you, Chair. So as Matt has described, we contribute based on a risk share basis to the Welsh Risk Pool, and that obviously is subject to increase based on the number of claims that go through. So we haven't got clarity on it now, but it is something that we will feed through PFIG if we get any updates from the shared service. Thank you.
Okay, Richard.
Thanks, Mark. Just a quick question on complaints. I think personally I'd find the section a little more useful if there was a bit more detail on where the complaints are falling. I know it's covered in a narrative sense, but something just setting out the figures for particular service areas or locations would be useful. But I'm interested in the reported figures for February and March 2022, where we got 364 complaints received, of which 343 were early resolutions. 89% of the early resolutions were resolved satisfactorily. 89% of 343 is 305. So does that mean that 38 early resolutions were not resolved satisfactory? I'm just wondering, what is a resolution, and how does it work for the balance above the 89%?
Yeah, thanks, Richard. So the way that we manage complaints is that they can be classified as either a formal complaint, which we have to investigate under the PTR rules, or an early resolution, which we should complete within 24 hours, so generally by completion of the next working day. And those early resolutions are something that we've been working very hard over the last 12 months to address. For clarity, it's 364 complaints and 343 early resolutions. So it's not 343 is a subset of that. They're two separate figures. So we managed to resolve 89% of the 343. In the majority of cases, early resolutions are unsuccessful because we were unable to respond within that 24-hour window, in which case, by law in Wales, the PTR legislation, we then have to move it into the formal complaint process. So the vast majority of those were we were just unable to respond within the mandatory time window that we have.
Okay, thanks. Thank you, Mark.
Thanks, Richard. Thanks, everyone else. Just going back to the point about complaints handling, Matt, I hear your observations, but we're currently running at 40%, as I judge it, rather than 75% in terms of the 30-day response rate. And I hear your suggestions it's going to improve if services can get on top of it. Yeah, I know you'll keep it under review with Lucy, but if it doesn't show signs of improvement, given our performance, we are going to have to consider other options in terms of how we ensure that the necessary assistance is put in place?
Yeah, of course, Mr. Chairman. So regrettably, the Health Board has, I think, struggled with this measure for a great many years, and we did in April 2020 start to make some significant improvements, but unfortunately that position started to deteriorate around the sort of late autumn, early winter of last year, and we've not been able to recover that position. We certainly will keep QSE updated. We bring a regular patient experience report that breaks down all this information down to divisional level. And yes, thank you. Anything we can do to address that position, I think, would be welcome from my perspective. Behind every complaint is an opportunity for learning, improvement, and a patient or a family member that wants answers and resolution. So I welcome your commitment and support to try and address that. Thank you.
Okay, thanks, Matt. And then finally, from me, there clearly is a concern being expressed by the coroner in terms of the number of section regulation 28 notices that we are receiving. Joe, I know you and Nick met with the coroner quite recently, albeit about a discrete subject. It'd be helpful to get a sense from you or Matt or both about how the relationship stands with the coroner and whether they are satisfied that where they are raising concerns formally that we are seeking to respond to them in timely and robust fashion. Joe or Matt or both? Or Nick? Nick, you can come in then.
If helpful, I can come in first. I've met with the coroner informally a couple of weeks ago, and I know that further meetings are planned over the coming weeks. I think there is a good working relationship between us and the coroner. Clearly, we need to support the coroner in his office's statutory duty. Part of the numbers, and this is in no way any complacency at all, Mark, quite the reverse. Of course, the coroner is dealing with a significant backlog in inquests following the COVID delays, and my heart goes out to the families who've been waiting a considerable amount of time for those inquests. But we are working closely with the coroner to understand thematic concerns, both geographically and in relation to further incidents, and that conversation continues. Thanks.
Okay, Nick, thanks, Matt. Right, I'm going to now move us on, if I may, and I'm going to skip through the closing business items and come to the summary of private business we reported in public, which is listed for your information in terms of that report. And I'd ask that you note the date of the next meeting, which is the 21st of July. With all of that said, I now propose to exclude the press and public and close the public meeting.